our next speaker is going to be discussing the intersectionality of professional pain cultures, research, academia, healthcare, and the clinician. And our next speaker is Michael Falcon.
Test. Good. Hello, everyone. Hello. I know there's a number of people in here that do presentations, and it's always awkward to hear your bio that you wrote, submitted to be heard, and for them to read that out, and you're just thinking, damn, I should have made that shorter. So I did not want my bio to be read. This is an interesting conversation because it was, well, the slides for today's conversation were developed between the time of 4 a.m. and now. My process for this, so I've been thinking about this conversation for well over a year now. I know Rajam asked me if I had a conversation for this year, last year, and I was thinking, yeah, I can come up with something. And so I've been stuck on this topic for over a year. Now, stuck would imply that maybe I haven't been thinking about it or I didn't really know what I wanted to talk about. It's more about the direction. As we'll talk about, hopefully as you'll realize, culture is this thing that is so much more complex than I think anybody truly appreciates. I have, my license is in occupational therapy. My degrees are in OT. And I would argue it is the most complex healthcare profession that exists. With that being said, we suck at culture. And I think that says a lot, considering my perspective, considering my scope of practice. I think our theoretical models significantly undervalue culture. I think we as humans tremendously undervalue culture. And when it comes to this professional realm, where I'm going to assume all or a majority of us operate, it probably gets even worse. And that's a very uncomfortable space to be in. Myself, Gilletta, Melanie, we were talking last night, and I was thinking, man, have them two start the day off, have me go in, and then who we're ending with today, there's a chance this could be a really uncomfortable room before Saturday and Sunday even gets here. Who was, just by a show of hands, I want to know sort of what my audience is like. Let's see, physios, really quick. Thank you. OTs, thank you. I'm expecting a lot out of y'all. Psych, any massage? Okay, what about academia? Research? Okay, and then a lot of clinical in there. And then I think we had a physician, right? Did we have a physician? A couple, okay, good. My token physicians, good. Unlike Melanie, I will be aggressive towards y'all, so don't take it personally, but you can if you want. So let's go ahead and get started. When it comes to cultures, it tends to be a relatively vague conversation, a relatively vague term, and sometimes, well, I would assume all of the time, it's easier to appreciate, or at least to begin the appreciation from the concept of the macro cultures. These are the things that we probably know about, yes? Myself, Latino, Mexican American, yeah, we can appreciate those things, right? Those macro cultures, those overgeneralized Asian culture, right? The overgeneralized European culture, the overgeneralized American culture, the overgeneralized Latin culture, right? We can appreciate what those are. Those tend to come with conversations around beliefs, values, shared values, goals, ethics, right? We can tend to appreciate what those are. Those sort of make sense. We can go on into sort of music, food, spirituality, the symbols, the language that we use, right? We can appreciate culture from that perspective. It's fairly simple to a degree, right? We can understand it. We can also understand that that's complex, right? Those things are complex. They make each and every one of us unique and individual as it relates to culture. Culture's not static. It's this thing that is always in movement. It's constantly adjusting. From the second we emerge from the womb, culture is being implemented, is being influenced on us as humans. This quote, semi-quote, describes culture as this ever-emerging array of collective values, ethics, assumptions, and ideas. And the piece that I'm going to spend, I think, quite a bit of time maybe illuminating, highlighting, and trying to put into context as we, I'm going to say, need to appreciate, or at least begin to appreciate, is this multi-dimension piece of culture. I'm not going to go into it now, but it's multi-dimensional. It's not as linear as we tend to appreciate it. Now, I actually stole this slide from myself. I took it from my global course with my OT students currently. So one, I'm sure they'd appreciate that. They'd probably also get mad at me for all the texts that I have on this, this conversation, but they're not here, so that's fine. So these quotes or conversations, concepts, come from actually an OT book. It's an international OT book. And I love the perspective that they give on culture. Culture is not about universal truths, rather it involves ways of being, doing, and thinking. So when we think of culture, sometimes can get misconstrued for concepts like social impressions or societal influence, societal agreements. Those are a bit superficial. Culture speaks to the underlying values that influence those agreements, those consensus, those pieces of consensus that society has established. If we think about it from a professional perspective, we have evidence, right, that helps us come to and or arrive on these socially accepted truths and agreements. It's the culture underneath it that allows us to accept those things as truth, okay? That is the culture. It's much deeper than just that sort of, that more superficial social piece. Culture is diverse. It is a diversity of values, beliefs, and behaviors found between and within cultures. Now, this is where it starts to get into that sort of multi-dimension piece of culture. We have and we can appreciate sort of the macro cultures, yeah? Underneath that are just layers and layers and layers of societal cultures, organizational cultures, individual cultures, all of these different things at play. And they're constantly having influence. You and I are constantly walking through, emerging through, having been influenced and exposed to everyone else's culture, right? This Pain Society has a culture in and of itself, or this Pain Summit has a culture in and of itself. We've already heard very early on, this collection of individuals, for whatever reason, tends to feel different when you're here at this location with this group of people, for whatever reason. Now, there's a number of groups of individuals that we see each other at different conferences and things of that nature, and you can feel the different energy at different conferences, right? Here, immediately, day one, you see people hugging and kissing and all this shit, right? It's like, what is happening? What is wrong with these people, right? It's a different culture here, right? Now, each and every one of you brings that same culture here in the same way that you took that same culture to, maybe I won't name names, but other conferences. You're not doing the same thing there, right? It's that multi-dimension interaction of cultures that changes how we present ourselves, how we behave, how we assume certain aspects of life. And this last one, culture is inseparable from temporal behavior and social aspects of, it says occupation. That's definitely an OT term. Occupation meaning anything that is meaningful to an individual that they want and or need to do in their life. Culture is inseparable, temporal, behavioral, and social aspects of life. Temporal meaning time, the amount of time that we spend either in a certain culture, exposed to a certain culture, practicing or believing from a certain culture, has a profound impact on who you and your culture is going to be, how it's going to be defined. Behavioral tends to be what we appreciate most about culture. It's how we operate, right? It goes back to the values, the ethics, the symbols, things of that nature, spirituality. The social aspects are a significant piece, and I think it has a lot more play into that sort of multi-dimensional piece of culture that I started talking about. And I'll spend a lot more time on that piece, especially after a few conversations that we've had here in the last day and a night, that have had a significant influence on sort of where this conversation is going. And then there's this concept of individual culture. This is one myself and my students have spent a lot of time on here relatively recently. And I think this is where my headspace has been, honestly, for the past year in thinking of preparing for this conversation. Because here I think there's a lot happening that we're not truly aware of, or that we do not fully appreciate, that we're not completely mindful of, and certainly not always mindful of. So if we take this concept of individual culture, how it develops, each and every one of you is represented by this line as an individual, okay? Literally from the day you emerge from the womb, you are being exposed to a culture, and another one, and another one. And this is that weird time during adolescence where there's probably way too many cultures influencing you, but you're being influenced there. And we continue to go through life up to this present day, and this is the information that is influencing your individual culture. Who you are as an individual. This is what makes you you. It's what makes you unique. And the fascinating thing about this concept, right? Melanie's talked about having triplets. You can take each one of her children, born and raised in the same household, being exposed to the same exact experiences, having the same exact opportunities. Everything is the same, identical, being exposed to the same exact cultures throughout their lifetime. And their individual cultures are going to be different from one another. That is interpretation. That is their own unique appreciation from their space and time of those cultures, what they mean to them and what they're not going to mean to them, what they will adhere to, what they will not adhere to. It'll end up defining what their culture is. A different way of appreciating this is sort of this, a different visual to appreciate this same thing. If each one of these circles, ovals, is a different cultural influence over time, that overlap, the things that you adhere to, the things that stick, the things that you identify with, the things that you find valuable and meaningful in your life, that's going to create your individual culture. Yeah? Now, when we think about it from this perspective, who you are, each and every one of you as an individual, is this complexity, this ultra-complex cultural being that has been influenced over time from the point of birth, I'm going to even argue even before that, to today, makes up who you are and what your culture is, how you would define that. Now, I had talked about, it's an interesting lineup that Rajam came up with this today, because my hope for this conversation is that we can be uncomfortable. My hope is that we can be vulnerable. My hope is that we will likely be a bit problematic. I love that concept. I love chaos. Conflict, I think, is a valuable piece of any experience. I think it's valuable and probably needs to be further appreciated in this space, in the professional space, whether it be healthcare, research, academia, in the clinical space. And when we think about academia, this is going to be, we're going to break up now and do a little bit of conversation, because I really want to establish what the sort of what our collective appreciation of culture as it relates to academia and research is. And trying to put a conversation around this, trying to put words to this, what it actually means, what it feels like, what it means to us, what roles are we going to identify within these spaces. Now, you don't need to be an academic, you don't need to be in research to have a role with this. Why? Because even if you're only in the clinical space, you absorb these things, right? I spoke about that multidimensional piece of culture. This is how it plays out. We have the academics and the research experts, right, that are fully immersed in this world, in this culture, in and of itself. As absorbers of this research, as absorbers of this academic world, whether it be as a student or now as a working clinician, as a professional, you're also being immersed, influenced by that culture. So before we start having this first initial conversation, we'll start with academia and research. I want to make things a little uncomfortable. So I'm going to read a quote, and this quote comes from somebody much smarter than me, 100%. It actually comes from a policy brief on culture published by the World Health Organization. And the policy brief is on culture and health and wellness or something along those lines. And it's, well, it could be a little profound. I don't know. I loved it the second I started reading it. And it goes like this. It is clear that randomized controlled trials based on a limited set of variables cannot yield a nuanced understanding of how risk factors are compounded in daily life. Furthermore, no degree of research, quantitative or qualitative, can adequately reflect the diversity and complexity of human societies and inform truly equitable policies when vulnerable groups face barriers to participation. Critical resources may be wasted when funneled into reductive or inadvertently exclusionary studies and into the limited policies and programs that they inform. Now, to my researchers, I am sorry, but I love this, right? Because it's going to challenge each and every one of y'all. Again, I did not write this. I am grateful that it exists coming from the World Health stage, and I am appreciative of it. And I think it sets the foundation for some interesting conversation. I throw this in front of your face, and I say, let's establish, through conversation, what our culture is, what our collective culture and appreciation is around academia and research. Now, I wrote these questions and concepts just as discussion thoughts to consider as you converse with your colleagues around your tables. Consider these things as you go through. I want to highlight what roles exist, because that's going to get at sort of that multidimensional piece that I'm talking about, and I want to talk about it even further when we're done. So, have fun with that. All right. Hello. Oh, thank you. All right, so I'd like to have a conversation. I do want this to be open, and I do want it to be safe. So if we can appreciate that, if we can agree to that, that would be great. Obviously, the academic and research world, I don't want anybody to feel pressured to express or to say anything from a certain perspective that may or may not get them in trouble. So please, let's keep this a safe space. If you can't do that, there's another conversation at like 3 or 4, something like that. So please, you can come back. With that, I'm curious, what were the conversations? What came up to you? What came up in your conversations? What stands out?
We barely got to the questions because we started with our positionality. We didn't feel like we could answer this without getting into who are we, where are we from.
Expand on that. No, expand on that. Because that's important.
I mean, like, we really didn't get into this. But we just felt, how can we have this conversation if we don't know anything about each other? Some of what we talked about was cultures, but even like positions of power, right? Mm-hmm. And those dynamics.
Yeah, absolutely. No, great start. It's an OT, by the way.
So we started out with the broad/narrow lane that the research and the treatment protocols come basically from a cis, white, male, healthy college graduate, and treatment protocols are written off of that. And we discussed how there's lots of populations that don't fit there. And then our conversation kind of concluded with, how do we communicate now as clinicians with the client who treatments and therapies are all failing once they don't sue us because they didn't follow the treatment protocol, and when we try something different than that, they don't. But also how to communicate with them that they're not failing, the treatments are failing them, but that's not everything we have to do. And then how do we put on our thinking caps that I spent a bunch of years in school, I'm smart, let me figure this out.
I love where you started with that. It's such a massive influence, I think, in modern research. So we can attribute this, we can generalize this a bit. Modern research, Western research, the Western influence on research, eventually we'll get to the clinical world as well. Modern influence, or the influence of modern medicine, Western medicine, on everything. Not only the individuals that are working in the academic world, but the individuals that are funding the research in the academic world. The individuals that are receiving the results of said evidence in the modern Western world. That level of influence is significant because it impacts every level, every systemic level of the academic and research world is being influenced by those variables, yeah? I'm gonna stop there because we have more. This is gonna be a good conversation.
We were just chatting. One of the jobs I had, it was a very interesting role. It was a neuroplasticity research center where we were studying neuromodulation devices for brain injury. And I had the role of the clinician on the team, and then after the devices were approved by Health Canada, we kind of had to change our clinic from a research center into a functioning clinic and hire a team and integrate the new evidence and new research into everyday life for patients. So it was so interesting for me to teeter that line between the researchers on our team and the clinicians and kind of explain to the researchers, well, no, the patients can't come every day for 6 weeks and stop working and not get paid to do the right protocol for the evidence of this study. Like, it was just very interesting, like that roadblock was so hard to navigate through. And even with the patients, me recognizing, okay, it's clear, I think that there's some mental health concerns going on with this patient. Like, I'm gonna deviate from the protocol because we need to provide the proper care for this person. And just like hitting my head against the wall constantly because they're so rigid sometimes. And I get why they need to be. Like, I was on the other side of it as well. You're trying to gather the evidence. It has to be clean. It has to be done properly. But we're working with humans, and that's not linear. So it was just challenging.
It's interesting because you said, I get why we need to be linear. I get why we need to be strict. Culture enforces that belief that we need to be linear and that we need to be strict. I'd push back on that and say, why do we need to be linear and why do we need to be strict? There is nothing linear or strict about life and the life experience. When we're talking about pain and the lived experience, good luck trying to fit that in a bubble, right? Trying to control for every variable of an individual's life and then manipulating one and then presenting that as if it's valid evidence and research on the lived experience, get out of here with that one. Let me educate you, right? That's an interesting concept, right? Why do we believe the things that we believe? Why do you believe those things that, yeah, through your education, through career research, through clinical world, through the community around you, that culture that you're working in, why are those even the beliefs? That's the cultural influence. It's underneath all of those things, right? The rules and laws and expectations of academia and research, why do we believe those things, right? Now, I'm not challenging or making the argument that it's right or wrong, but the critique and the self-reflection, the appreciation of why do I even believe those things? I don't know how I got here. Something happened there. That's cultural influence, right? Oh, then you.
I'm glad that we were able to get to know each other first, Sheila, because we then had skipped that part. But I agree that that would be foundational. But one of the things we were talking about was for physical therapists in the United States, we have a test that we have to take, and the test is the same for everyone. And so we end up with a problem where academia has to teach you the things for the test. The test banks are probably not super current. And so things like Therapeutic Alliance don't make it into the classroom, even though our faculty knows how important it is, because that's not something that's going to show up on the test. So I don't know if that's like a role, but the test is a stakeholder, for lack of a better word, that influences our academia.
The test, no, but the accrediting body, yes.
Sure.
The accrediting body is not here in the room. The culture around evidence-based, yeah? There's an evidence-based culture that exists here, there, everywhere around this type of world, right? We're talking about healthcare. I'm going to generalize and say healthcare. The accrediting body is not here, right? The evidence is here. We're talking about it. You're going to have 3 days of evidence where we're going to bombard you with the evidence, and yet the accrediting bodies aren't here to ensure that the evidence is integrated in. So then what the hell are we teaching the students? What are they basing where are they going with it, right? We are just reinforcing the same shit over and over, and they're just going to come out and have to come to another conference like this to be almost re-educated. They need to be uneducated to allow them to be educated in this stuff.
That's a really interesting and important point. What does profession accept to exclude others, right? That's what accrediting bodies are about. It's about excluding and creating those walls. But to come back to the culture question, I'm a physician, but I do integrative medicine, acupuncture, and addiction medicine, and started in Western medicine, right? But in learning East Asian medicine, the orientation is completely backwards, basically. Instead of research and academia based on cutting edge, creating new evidence to prove a new hypothesis. In Chinese medicine, we go back to the past. Mm-hmm. Everything we know, it's because our ancestors knew it before us. Mm-hmm. So even the sense of time is completely reversed, where we think of time and going forward in front of us, one foot in front of the other. But the reality is what's in front of us is a mystery. It unfolds from one moment to the next. What's really in front of us, in a more literal sense, is the past, because you can look at the past. It's been there. We've been there, right? So that's where the knowledge lies. That's where the heritage lies. And how do we compare these things, right? Ted Kaptchuk wrote a book, The Web That Has No Weaver. He's published a lot on the placebo. And one of his early papers, I think it's called The Golden Calf, or the Gold Standard. I can't remember the exact title. But he poses the question, makes the point that there's no RCT to show that RCTs are the gold standard. But that is culture. That is our culture. We believe that's the highest level of evidence possible.
Yeah.
Is there someone up?
Yeah, right here.
I was thinking about going back to one of the earlier definitions that you quoted, an ever-emerging collective of values, ethics, assumptions, and ideals. And so if I were to draw a circle around academia and research, I understand this assignment to be, what do I think the assumptions and ideals and collective values and ethics are in academia and research. And I think one of the foundational ones is that there is knowledge that can be objective, and so the goal of research would be to discover that knowledge, and the goal of academia would be to promulgate it or disperse it or transmit it. And so, there are all kinds of assumptions built into that.
Yeah.
And I think you've talked about some of the cultural, alluded to some of the cultural heritages behind that, and Dr. Lee likewise. But I think that's an important call out in terms of just saying, what are the operating assumptions that help to build the culture that asks the research questions or is looking at evaluating funding or all kind of the downstream things.
The assumption that knowledge is objective is a fascinating appreciation that for some reason we have, right? It's not even considered valuable unless it is objective, yeah? It needs to be done. Research needs to be done in an objective way. So we need to study individuals in their life from an objective perspective. How does that work? How do you understand? How do you understand? I'm going to get to understand in a second. How do you appreciate life objectively? That's hard to do. So you want to dehumanize yourself as researcher, as academic, as clinician, to appreciate somebody else's life experience. That seems a little twisted. That seems uncomfortable. That seems, I don't know, too aligned with AI for my comfort, to be honest. It's a whole other conversation. Was there another one? Yeah.
So one of the things that I do is I occasionally am asked to provide peer review for a journal. And one of the things that I've noticed and that I try to take into account when I'm reviewing a paper that's been submitted for consideration is what are some of the biases of the people that conducted the research and how, not only in how they designed the research, but also like how did they write and interpret the results.
Yeah.
And there are some that I've been really impressed with how they were able to kind of put what I would expect to be their biases to the side and really present excellent methodology for breaking things down to try to get as objective a perspective possible, but also like how do they discuss, the limitations of what they did and the results that they found. And other times it's their personal biases or professional biases, as the case may be, are glaring and permeate the entire paper. And in some cases, their underlying assumptions for justifying why they did the research in the first place are based on things that have already been debunked years ago. And so, these are things that I have to factor into doing my peer review and giving feedback. But also, I've noticed that all of the papers that I've reviewed so far for this journal is that all of the papers I've looked at so far look at things from a medical perspective. They're looking at things from, in terms of like pain, function, things that we would normally include in an assessment of some sort. But I've seen other papers that I did not review, and one that really impressed me was that the person that designed the study and wrote the paper, she took the standard medical model of assessment and set that to the side, and she looked at things in terms of like in terms of communications theory. And so what she looked at was how do outcomes of this, how do outcomes vary depending on whether or not the intervention or the therapy session, as the case may be, how did that align with the patient's expectations prior to that session or prior to that intervention? In other words, whatever, if it did, and what she found was that if it didn't align with the patient's expectations coming in, they were less likely to have a positive result going out. And I don't know if there's been much follow-up research to kind of dig deeper into that, but I just found it fascinating that that it was a completely different perspective, really looking at this piece of communications rather than going into pain and function.
You started with a comment about, one, thank you for adding another role to this concept, that, right, our reviewers, especially for our journals, the concept of bias, removing bias from research, removing bias from how you write, that's not possible. We're humans. We have culture behind us. It influences who we are. It creates and establishes those biases, right? It is who we are. That's the first piece. Second piece, there's an assumption that we cannot work together if there's not an alignment. Conflict is a very healthy thing. It can be fairly progressive in how we operate, right? The relationship between you and any other human, it doesn't matter what the dynamic of that relationship is. Which relationship in your life is in complete alignment? Good luck finding one, right? There's no such thing. You don't have to be aligned for progress to be made. What you have to do is make the concerted effort to find some consensus, right? To figure out where the two different perspectives can come together and encourage a progress, encourage some type of positive outcome. It's an interesting concept, right? Those are underlying variables that impact us. One of the variables, one of the roles that we didn't talk about is us as we absorb, those of us that absorb the research. Which cultural influences are at play when you absorb research? Largely influential by how the research is written, largely influential by how the research was done. An article comes to mind. I'm doing this thing with NIH, and an article was submitted for us to review. And definitely it's in the pain world, and it's a fascinating thing. And I got stuck on this one section with the methods, illustrating, how they did their research and the whole process. And they did like this consensus methodology, blah, 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 whatever. Their methodology for their lit review was throughout certain time period, restricted to certain regions of the world, filtered out by English-only articles. And I'm thinking, okay, so this consensus methodology, meaning, okay, those of us that are the experts, based on what we agreed upon, our outcomes are going to reflect that. Certain regions, okay, so Western society, so based on what factors and variables and pain influence and research is out there from a Western perspective, that's going to influence this article. Oh, and it needs to be in English, which that was the one that kind of stuck with me. And I'm thinking, in today's world, with how easy it is to get an article in another language, in a language that you can comprehend and that you can read, why the hell are we filtering out for English articles? The amount of bias that comes from that type of article, and the only reason I didn't put it up here, because somebody would really get pissed off at me, and I don't care, but I would assume there's probably some people that would care. Now, this is a fairly prominent article, and I thought it was hilarious that this is in there, that this was the methodology, right? There is so much cultural influence that is happening there, and so many of us in this room have likely read this article. And it has, for whatever reason in this world, it's had so much influence, and it terrifies me that that's where we go with some of these things. Anybody else? Okay. Thank you for that. I hope you're somewhat uncomfortable. We're going to take a break, and then we'll come back at, I don't know, what is it, 15 minutes? Is that what breaks are? 1:10. Okay, thank you, thank you, thank you. All right, thank you all for coming back. I appreciate it. So very similar to, I guess, sort of how we ended. I want to do the same sort of activity with cultures in healthcare and sort of the clinical world, especially as your roles as clinicians, for those of y'all that are in the clinical world. But as we did in the last one, I want to start with a little discomfort as motivation, as influence. Precisely because culture concerns more than what we acknowledge explicitly, recognizing it involves the difficult work of scrutinizing assumptions, questioning perceived truths, and appreciating how shared group values can, for better or worse, sharply diverge. For better when difference helps us creatively to adjust our assumptions, and for worse when difference leads to misunderstanding and conflict. We talked a little bit earlier about sort of the alignment of culture, or alignment in general with the relationship. Culture is this thing, if we look at it from the macro culture perspective, there is a lot of conflict historically that we can tie back to and say the misalignment, the malalignment of cultures has a large influence on where those conflicts come from, or at least what influenced them. An interesting truth, I'll say truth in quotes, about sort of our culture and what we're talking about here is that that same phenomena can exist, yeah? Malalignment of the cultures can be a very negative thing, right? It can have an impact. It can create these cultures that we exist in that end up being toxic, that end up being unhealthy, that end up causing conflict in a negative way. But it is also true that it can help with creativity, and this is what I was getting at earlier. When there's malalignment, it doesn't always need to turn negative. It can have a positive outcome. It just takes some creativity. It takes some ingenuity. It takes a little bit of humbleness. Takes a little bit of empathy. It can have influence on where we go with what we want to do. Now, this is also pulled from that same article or that same policy brief around culture. And again, this policy brief is directed towards us. It's directed towards healthcare, the global healthcare. So I want to go back and do this same activity, but I want you to focus on the healthcare and the clinical world. Be a bit vulnerable with this, even more so than you were willing with the academic and research world. This is, in my opinion, this is where the value is, right? This is where the rubber hits the road, especially for individuals like myself, those of us with the lived experience. If you're not willing to make this change, if you're not willing to confront some of those things that make you you, to identify those cultural variables that make you you, that influence that relationship between you and your clients, we're not going to see a damn bit of change in this world. We're not going to see a damn bit of change in the pain world. And we're going to continue to just come back to this type of conference year after year and honestly just hope that maybe something changes. The change is going to come here, in that self-reflection. So please, converse. Okay, okay, hello, hello, hello. Hello, thank you, thank you. I don't know why that works. That always works. It's the most subtle thing I could do, and it's just, oh, there it goes. That's probably culture, to be honest. It's universal. Okay, let's have a bit of a conversation. I will probably blow through the next break, and then we'll just cut it 15 minutes early. Is everybody cool with that? Okay, perfect. Conversation around these cultures. Who wants to start? Oh, hold on, hold on.
Okay. Can we hear it or not? Okay, perfect. Okay. Okay, she's still talking. Sorry. Yeah, no, because we have a really great, diverse group at our table. I'm an occupational therapist. We have our awesome Australian exercise science physio, and we have a DO, and we have a psychotherapist. So that was really great to talk about that. Things that really came up are variables beyond even just this healthcare clinician role. We started to bring up the fact that, and I can't speak for every part of the world, being a US trained and practicing therapist, but that variables that influence and inform, this is now turning into a business. This is third-party payers and insurances influencing this, which at the end of the day is an absolutely horrible bottom line for humans. So we were starting to talk about that. And then the roles, and there's still such a high level of paternalism and power dynamics. Power dynamics of, is it a culture where if you're in a healthcare system or a hospital-based system, that are we physician-led? Are we nursing-led? That's still not allowing for, which I was commenting on, so many healthcare systems are saying, oh, we're person-centered, and to me, unfortunately, that's still really lip service because we're not. We're not. There's power dynamics and the roles where if you maybe are seen as, this provider, and can you as a different conservative care clinician actually feel like you can have an open and transparent conversation about a shared person you're both seeing, not a patient, a person, and those power dynamics are there. And then also carrying over from the academia side, yes, there's accreditation standards that all these programs have to meet, but there's still this dichotomy of, oh, well, we're this university and this is how we train our physicians, or this is how our therapists are trained, or there's so many different layers and levels here, and there's just so many different things. I'm hopeful that that can change if we have these open and honest conversations about that. Because I posited to my group, I said, a lot of times we talk about an ultimate goal of having not multidisciplinary, not interdisciplinary, but transdisciplinary. Yeah, and you're shaking your head because it's like, what is that? So just talking about this, talking about these different layers that are there, and that they're so influential, and that if we're going to actually do right by the people that we want to serve and be present with, to humanize all this.
Transdisciplinary, the reason I'm shaking my head is the world is nowhere near that. We can't comprehend what that would be, how we could do that. In IASP at the moment, I'm on an interdisciplinary panel or task force, and we're struggling to identify what interdisciplinary practice looks like and what it means, how to define that. Which brings up the conversation of interdisciplinary teams. That's a fascinating concept. It sounds beautiful. It sounds incredible. How many of you can define what an occupational therapist is? Yeah, case in point. Who cares about interdisciplinary teams when you're not even taking the time as some of the most educated minds in the world are here in this room, not even going to take the time to figure out what the respective professions do and what they can do for your clients. We're proposing this concept of interdisciplinary care, let alone transdisciplinary care, and we haven't even taken that initial step of learning what the other professions do. There's some underlying cultural variables at play there that I'm like, what are we doing? Why are we even here, right? That's evidence-based, yeah? Interdisciplinary, even multidisciplinary, right? Take it down another level, multidisciplinary. Let's not make it so complex with interdisciplinary. We're still not there. We have no clue. I would have loved to see the two tokenistic physicians in the room raise their hand and be like, oh yeah, I know exactly what an OT can do for my clients. Sorry, or my physicians, I love you both. Love you both. It's not a shot. But that is the culture at the moment, right? That's where we are. It's unfortunate. Comment in the back.
Yeah, from the online world, tuning in here and that a conversation that revolved around the culture of ableism and how it impacts the entire chain from research assumptions and methodologies down to patient experience.
I'm going to get into patient experience. Yes, 100%. It impacts all of this. That multidimensional piece of culture, I'm going to get to that. I will get to that for sure. And the patient experience and what it does there. You know, there was one back there and then here.
Thank you. So many thoughts.
Sorry.
So we here at this table are an interdisciplinary team. We have physical therapist, pharmacist, nurse practitioner, physician. We have a nurse on the team as well, psychotherapists, as well as social workers. And we struggle with that.
Wait.
Yes.
And?
I'm sorry.
Oh,
not in the budget for OT right now.
Unbelievable. You're not multidisciplinary. Get out of here.
I know. But we fought tooth and nail to figure out how to work as a team. Starting with the definition itself, it's been a struggle. And I think we've made a lot of progress, a tremendous amount of progress. What I was arguing early on, we've been doing this for about 2 years almost, longer maybe. Just because you are on the roster as a team, you're not functioning as a team necessarily. The difference between being on the golf team versus being on the football team, each position has their own roles. But it's even more complicated than that because each of us has our own expertise in these fields. So it's more like putting the captain of the baseball team with the quarterback of the football team with the center on the point guard, whatever, on the basketball team, try to create a new sport here. And we've been trying to do that this whole time. But that was one thought. The other thought I had regarding the third-party pairs, again, we're in the VA. This is a centralized or basically it's basically socialized medicine, right? So the bottom line is really still, how can we best help the veteran sitting in front of us? We have the incentive of looking out for their well-being and health as opposed to the private sector in which a sick person in a hospital bed is very profitable, right? And so until you take profits out of healthcare, you're never going to solve that problem.
Imagine, what does a healthcare system that is dependent on a certain percentage of disability to function? That's what healthcare is in the United States. We need a certain number of beds to be filled in every hospital for our system to survive. What kind of culture does that impose on individual clinicians? What does that do to our nurses? What does that do to our physicians? What does that do to our clinicians? And most importantly, what the hell does that do to the clients? How does that even work? Where is that supposed to work? You want to talk about the impact of the community? That's another role that we haven't talked about yet. What does that do to a local community? It decimates it, or it makes sure it can never thrive, because we need a certain percentage of disability in the community for that community to have a hospital, for that community to have a healthcare system. That needs to be there. We need disability for us to have jobs. It's sad. We should all be thriving for unemployment, right? In an ideal world, we would all be unemployed. Why? Because there's no need for any of us. 100% health in a society. That's what we have to thrive for, right? That is a twisted logic. Imagine what that does to your individual culture. How does that impact you as a clinician, as a researcher, as an academic? How the hell do you educate students to be excited about this profession that is going to thrive because we have a certain percentage of disability in the community? What exactly are we working towards? There's a very healthy language to define this. It's really fucked up.
In one sense, I think you're preaching to the choir.
Oh, 100%.
And what we need is policymakers here. We need healthcare organization CEOs here. We need legislators here to help make those changes happen.
Yeah. Yeah. We need accrediting bodies, right? We need presidents. We need all of that.
I think, yes, we do need those people here, but I think also before that, and to help make interdisciplinary and team works better, is we all need to learn, this is kind of really sound harsh, we need to learn how to stay in our lane. We need to learn that, yes, my client's complaining or my client's going on about their story, and I can listen to them and I can be empathetic and I can offer encouragement, but the best person for them might be to go see this other therapist. And so highlighting everybody on the team and maximizing who those different people are. And I might be jaded to my position on this. I come from an online world of trying to move to online healthcare practice, of helping people in pain begin to move again, begin to not be stuck in their pain patterns, and to be able to find relief. Getting them onto the healthcare there is challenging, and I need to be able to sell exactly what it is I do.
Right.
So us as clinicians knowing exactly what it is we do and staying in that lane versus going off to others. I'm the person who does knees. You might be the person who does necks. Here's the person who does elbows. Yes, I got taught all of that, but what I'm best at is. So I think that helps. Another question that I've had with this day is, as we're interacting with our clients, from an online world, as I'm interacting with someone and I want them to come back or I want them to become a client getting greater services because it's their autonomous choice, because it's coming out of their pocketbook versus insurance, I want to give them 2 or 3 wins that they can walk away with that are immediate changes, immediate differences, that to have them go home and sell them on, Stephanie's the person who is helping me and can help me, and I'm going to go back to Stephanie as rabid as a fan as Taylor Swift has. And so there's the client interaction that drives that without being carpetbaggers, and also knowing what my lane is. That person will walk away going, you know what, I had a really great conversation with Stephanie, but I have low back pain, and she does neck pain. So she's not the person for me, but she told me some people to go to.
To a degree. I'll challenge that a bit, to a degree. Okay. I think there's a lot of variance in a lot of situations with a lot of individuals' journey, with a lot of different skill, with a lot of variance in expertise, with a lot of variance in appreciation for others' expertise. There's a lot of variance in resources and availability in certain regions. There's a lot of variance in general, right? What needs to happen, likely, maybe, who knows, is that there's a consensus, right? There's an established protocol process that happens to establish what is the best approach for whatever the given situation is. There's so much context and variance that occurs within each individual experience, each situation, every systemic opportunity, right? Coming up with a process that's going to allow for whatever best potential outcome of service is going to be in that situation. It's just, it's not as simple. In some situations, I would love for some physicians to stay in their lane. Stop giving me my rehab orders. I'm the rehab person, I can do it. But in others, don't stay in your lane. Learn about my profession. Learn about what I can do for my client. Learn about what I can do for your clients. Educate yourself that we share the client, right? That we are both on that same, right? So there's variance there. I think there's a lot that goes with that when it comes to context, or there's a lot of contextual variables there.
Yeah, I completely agree with that. And I think that we're on a journey hurtling forward into the future, integrating diverse fields of information. That's where we're going to learn more as we learn from each other. And I think if we stick to our lanes, we may miss the opportunity to learn from each other, but we're going to miss the patient as well, because you know, if I find myself in a fortunate position to help people with a whole range of bizarre, far-out, intersectionalizing presentations. And if I'm, you know, I think that I'm perfectly capable of helping people with low back pain, but what about my police officer patient with persistent hip pain that no one can diagnose or understand, who has comorbid chronic fatigue and a whole range of other dysautonomic presentations? There's no lane for that, right? We're out in the ocean. So unless you're saying that I need to be, you know, we're going to leave that for the ocean swimmers, I think we're just going to miss too many patients and miss helping the person that's in front of us. So I completely respect each and every one of us working to be better at the things that we feel a sense of interest for, but I do think that we need to, in some ways, treat boundaries lightly. But I also think that speaks to how we need to work on each and every one of ourselves as health professionals in terms of our leadership skills, because rather than saying that we have to own a particular domain, we're busy looking for other people to build up and lift up, to put them in a position to be able to help the person that's in front of them. And you know, when it comes to leadership and power structures, they're going to exist whether we like them or not. I'm not really a very hardcore anarchist, but you know, if we subvert that by actually turning leadership on its head as a culture and go, you know, how we lead is actually how we serve one another. I don't know, what do you think? I think that's how we iteratively get real change, but it's not particularly exciting.
I'm kind of stuck on what did you say? Not a significant anarchist, not a hardcore anarchist. Just a subtle anarchist. It's fair. I can respect that. Just subtly anarchist. No, I think it's going to take challenge. There's going to need to be a lot of challenge. There's going to need to be a lot of uncomfortable individuals, including ourselves. My hope is that would be the focus of this, the impact of this conversation.
And us better identifying our roles is going to help the management and the organizations.
It's going to help challenge.
To better utilize us and work together and make better policy makers.
Potentially.
Because it's
Potentially.
better identified for them.
I think there's a lot there, potentially.
Just to speak to the idea of lanes and staying in our lanes, sometimes I think the analogy is often kind of thinking in terms of like automobile lanes where it's pretty discrete which lane is which. I would invite us to maybe consider shipping lanes where things are a little bit more fluid. And I'm not going to flesh that out. I'm just proposing that as an alternative way to consider lanes. But the thing that I wanted to mention is that, there's a lag behind advances in research and the kinds of things we discuss at conferences like these. and what becomes part of curriculums in training programs, and especially at the school level. And sometimes, and a lot of us get frustrated by the slow rate of change. And one of the things that I have found is that a lot of people I've talked to that are really forward-thinking and really want to advance things and really want to do their best as clinicians are also not inclined towards seeking positions of leadership within our professional organizations, or participating or getting deeply involved in politics, whether it's lobbying or having communicate or getting into discussions with insurance providers that occur at a higher level. And I would encourage a lot more of us to to get outside our comfort zones, and maybe we spend less time face to face with individual patients, but maybe we can spend a little bit more time being part of the conversations with the people that do set the policies, do set the curriculums, do change the testing and the accreditation programs.
There's a lot there. As you were talking, I'm being mindful that the culture in this room has shifted and adjusted my focus, which I'm a little annoyed by, so thank you for that. Honestly, I'm stuck on the shipping lanes. That's a healthy analogy for culture and what is happening. These cultural lanes are there. It's not avoidable. It's impossible to stay in your cultural lane. It's not possible. Any given day, we are passing through and existing in all of these cultures. We are experiencing them. They are imposing themselves on us. You can't control that. It's there. So I felt like shipping lanes was a really good analogy. Thank you for that one. I don't know if I want to go too far into that second piece of that comment, because I will get fairly pessimistic about that stuff. And it's only day one, so maybe not yet. But conversation outside of this, I will have that conversation with you. I love that concept. Let's tear the world down, actually.
Just one agenda. If we are not part of the conversation, how will they hear our voices?
Damn it. I'm gonna say there's an assumption that they will hear our voices, even if we speak. There's an assumption that they want to hear our voices, and there's an assumption if they were to hear our voices that it would have any type of influence and change. Damn it. You shouldn't have taken me there. Go ahead.
I have a thought on that. So I'm Daria Oler. I helped to start Long COVID Physio. So if you don't know, we're an international association of PTs, OTs, et cetera, with long COVID. And we started because I'm saying, where the hell is the APTA? Like, I'm sick, and there are no resources. Like, we're trying to be heard, or if it's the CSP in the UK and all the other organizations, we're done waiting for everybody else. We're done with the red tape and the bureaucracy, so we just started our own association, like literally international, multidisciplinary, and we're able to get the information out so much quicker. We're able to speak as patients, so you don't deal with the cultural things within healthcare, like the ableism and the racism, because we're the ones speaking to it as a professionals / clinicians while / patients while we're still sick. So it's been really interesting because we're literally all over the world, and it's just amazing what can happen when you get out of like the traditional setting that we're in, and we're just going to run this ourselves.
And from a cultural perspective, what happens there is an appreciation, a self-reflection, an identification of malalignment of your culture and the cultures of which you and your colleagues work in, and say, okay, fuck this, we're going to make our own culture. That's the That's the potential for the progressive impact. When you start to appreciate where you are culturally. If it doesn't fit with you, do something else. Create your own culture. Yeah? There's nothing preventing us from doing that. Somebody messed up and gave this room all the degrees that we have, all the education, the skill to go and get the education on our own. And then now we have these connections left and right, and you're going to continue to foster these connections, foster these relationships. The impact of the cultures here that you're going to interact with is only going to lead to, in theory, progress. right? But not if you go back into the cultures of which you came and which you work and just continue to do the same thing over and over again. And I'm going to get to that in a second, too. Sarah.
I'm thinking about empathy as it pertains to the exercise. I'm still back on the title of the talk of the intersectionality of the professional pain cultures, right? And so I've been listening, trying to think, all right, how do I see and understand cultures that are not my own, right? How do I understand what it would be like to be a researcher when I'm not a researcher, or an academic when I'm not a full-time academic, or, you know, I do fit in this bucket, but and I think several things come up for me when I start exploring that. I hear a lot of othering going on right now. I heard it, you know, with the last one also, but and I just want to call that out as I think I hear that as an expression of grief and fear and sadness and disempowerment, but I also think it's the wrong way to build a bridge across professions, or maybe it's not the wrong way. It's a less effective way, and I don't say that to silence the voices of grief, but just to say the thing that has helped me is not to focus on what everybody else is doing wrong, but what's preventing me from doing what I could do better. So I've been reflecting on, you know, as a physician, I feel like the culture around medical training and practice is that I'm supposed to be perfect. I'm trained not to need. Am I supposed to stop?
Yeah, stop. Anybody else before I move on? I'm going to get to that, actually. Like, that whole conversation is exactly where I'm going with this. Come back with that comment and where you want to go with that.
It was a good
Yeah,
lead-in.
you're done talking.
So just briefly talking about roles and specialization, you may be good at, say, knees, for example, but if you are able to safely help a client or patient immediately who has neck pain while they're waiting to get in to see a neck specialist, I personally think that we may have an obligation to do that. They may not need the best neck specialist in order to get better. Perhaps we don't have all the really good hard skills that the specialist has, but if we have good soft skills, we can at least address a portion of what's going on, give them some measure of relief, reassure them, help them rebuild self-efficacy while they're waiting for either insurance or to kick in for the specialist, or for the specialist to even be available to take them on.
Respectfully, you just hit one of my pet peeves. And honestly, it pisses me off. It has nothing to do with you personally. But this is the culture that we operate in, right? So it's there, the soft skills. Oh, that annoys the shit out of me so much. Because the soft skills is exactly why we're in this place, right? Those soft things, as if they are inferior, not as valuable, don't have to spend much time on them, don't have to spend too much time working with in the academic world, with our students on what those are, just even calling them soft skills, right? These are the things that make us human. They're the things that allow us to connect to individuals. They're the things that allow relationships to happen. They're the things that allow community, of which we do not have in the Western world, but allow communities to exist, to thrive, and to survive. It's unfortunate that we call them soft skills. It's unfortunate that we have a perception that they should be called soft skills. God, that one pisses me off. But thank you for bringing it up. I love that. Okay, I'm going to move on because I need to. So I attempted to steer away from the culture of pain throughout this conversation up to this point. Failed miserably. Cultural influence. This is your fault, not mine. But now I want to speak directly to culture of pain. What this looks like, I'll stop there. I'm going to start for the reasons for this conversation. Over the more than last year, handful of years now, where's Joe's in the back sitting on the floor. Last year, Joe and I, we emceed Oregon Pain Summit or conference. I don't know what they call it. And on a couple of our drives, far too early in the morning to the conference, we were just talking about sort of where things are, kind of reflecting on how much progress has been made. We both work a lot in sort of the lived experience, advocacy, global space, and doing all this fancy stuff. And it probably was a very unhealthy conversation for us to be going to a conference that we were going to be emceeing, because it put us in a pretty bad space to start the day, because we have been doing whatever we do, I don't even know how to characterize it, for a long time now. Myself, whenever we first met is probably when I started, so however long that was, 6-7 years ago now. Combined, we're probably 15, almost 20 years combined, working in this space. And what we got to is maybe we've taken a step forward, maybe, if that. And that includes the individuals in this room, that includes the individuals that presented on those couple days in Oregon, probably going to include a number of individuals that'll present in the next couple of days. And it's not a negative feeling towards them, but it's more a reflection on why. Why haven't we made the progress? You have so much evidence in front of you, literally in front of you, year after year after year. More and more evidence comes to you, directly in front of you, tells you what the issues are. The pieces that are so impactful, the pieces that piss us off, the soft skills piss us off, the language, this obsession with understanding what I'm going through. That's a fascinating thing that I can't stand. I'll get to that in a second as well, right? That's what really sort of spurred this whole conversation. When we get to culture of pain, putting it in sort of hopefully a healthy perspective, really to end out this conversation. Encountering Pain is a book. I think Joe, I think you actually recommended it to me. It's a good one. Read it, get it, buy it, read it, absorb it, reflect on it, go back and read it again. It's a good one. This quote, for me, honestly has driven this last year and a half for myself in this conversation, and where I was going to go, or where I wanted to go, or how I even wanted to contextualize this conversation. Pain is represented and understood differently between individual people and across cultures, always in the context of the dominant medical culture. Thus, how we think and talk about pain is influenced by general cultural beliefs and medical ones that include physiology and even traditional pain-relieving medicines. The dominant medical culture has modern influence, has the influence of Western society, has the influence of Western medicine, right? We all know what it is, right? That big B word. Biomedical model, yeah? The biomedical model has so much influence, and this is where I really want to have this conversation about the multidimension aspect of culture and what that means. Now, culture has sort of the best way I have read, at least the way that I've read about culture in a way that makes the most sense to me, is by a health anthropologist, last name Weidman, forget her first name, separates culture into two sort of categories. There's the category that we've sort of already discussed, the cultural, or the beliefs, the values, the goals, in the macro culture, right? It's all those things, the spirituality, the language, all of those things. But then there's this other piece that's the social dimension. And it's in that social dimension that you have this multi-dimensional aspect that I think is largely at play. Now, if we take a step back and we go back through sort of our appreciation of how cultures influence individuals, right? Remember I talked about each one of those individual ovals is different cultures that we're walking throughout our timeline, throughout our day, yeah? And then at some point or another, we had this professional career opportunity where we chose to enter your careers. At that point, there's this overlay of biomedical influence, right? The biomedical culture is when you first entered that biomedical culture. The first time you were influenced and integrated and experienced that biomedical culture was when you made the choice for your professional careers. Everything up until that point, we just talked about every piece of that professional journey, that track that you went on, yeah? The academic piece, the evidence or the research piece that informs the academic piece, into the clinical world, the greater healthcare world, all of that linearly influenced by biomedical influence. The assumption is that that started when you chose that professional career. The multi-dimension piece of culture actually starts much earlier. The biomedical influence started almost at the point of inception. Why? Because the first thing in Western modern world, modern society, a mother is going to do when she thinks that she might be pregnant is do what? Take a test, or she's going to go to a physician. That embryo is going to be poked and prodded, literally, almost literally from day one. And that's where that influence, the very first influence of biomedical culture is going to happen. And it's only going to compound over time, right? Get back to that temporal piece of culture. Over time, culture compounds, especially with that temporal piece. The longer that you are exposed to a culture, the further the integration, the further the influence. So travel into infancy, poked and prodded, that is the experience of biomedical model, right? You're going to get your vaccines. This country, that's becoming a question, unfortunately, but you're going to get your vaccines, right? That's where we're going. Through childhood, in a neurotypical child, right? You're still going to get poked and prodded. That is your experience of medicine, of healthcare, of this biomedical model. It is being influenced onto you. It is framing what the role of patient is happening in childhood, in infancy. What does that do to when you get to adulthood, as a client, as a patient? It influences what you are expecting from your physician. I'm going to my physician because I feel sick. I'm expecting you to have the answers. This social piece is that interaction right there. Biomedical model has trained me from the point of inception that I should go to my physician because he's going to have the answers on how to cure me, thus imposing exactly what you were talking about. There's a pressure on all of our physicians, all of our healthcare providers, that you must know the answer, that you must understand. There's no option. You have to understand because that's what I'm expecting of you. That's that interrelatedness, that's that social interaction, that's that multidimensional piece at play with culture. Biomedical has a significant influence. If we look back at the macro cultures, the concept of spirituality is an interesting one. Now, spirituality doesn't have much of a role in healthcare directly, but we sure as hell treat biopsychosocial model like God's gift. It's an interesting concept. It's an interesting immediate fixation to a theoretical model that may have some influence. I can critique the hell out of it, but immediately this culture, this community absorbed that and said, yes, that is what we're going with. There's been very little critique of that model, especially in this space. Now, my OTs, within reason, my OTs, we can look at biopsychosocial model and say, oh, that's cute. That's a cute little model. In no way will a theoretical model of any type fully comprehend and fully appreciate the life existence of a human. Good luck with that. It's not plausible, right? But we absorb that. However, if we are so influenced and so ingrained already through a biomedical model, is it that you are absorbing a biopsychosocial lens and operating from that perspective? Or are you viewing that biopsychosocial model through that biomedical lens? Those are not the same things. That is not going to lead to the same outcome that potentially it could. Right? There's a significant cultural impact here that starts much earlier than I think we fully appreciate. And it has a much greater influence on the totality of the relationship between clinician and the patient. I was reflecting on Joletta's and Melanie's role play. There was so much there that I wanted to just interrupt and talk about, like, oh, let's go culture. Melanie came by right after the first session, and I was like, shut up, stop talking about culture, that's mine. So she started with a reflection with her daughter, and she asked the question, why is it so difficult to believe someone's pain in this clinical world, in this culture of the biomedical, right? From a cultural perspective, why is it so valuable that we need to understand that? Like, why do we have to get to the point to where we believe it for us to be able to work and provide that empathy to an individual, right? I would challenge that believing piece. Why is it so valuable to us? I don't even know if we can put words to why it's valuable. Why is it necessary that you need to believe your client that they're suffering? Why do you need to believe? Why do you have to understand it? What is the obsession with understanding? You talked about understanding. What's the obsession with understanding? Why do we need to understand it?
Because the client asks us and begs us to understand them.
Do they? I don't know that I wanted anybody to understand me. I don't know too many that really care if you understand. The opposite is very true. You're going to piss me off if you say that you understand. If you lie to me and you tell me that you understand. Right? One of Megan's comments was, talking about a patient interaction, and it's interesting how common that phrase is. I'm sorry, I'm going on and on, especially when you get a patient talking, when they're actually giving you the stuff that you want to hear. That's biomedical culture at play. I feel bad that I'm talking on and on and on about the things that I do not think that you want to know. There's an underlying cultural influence here that's causing this. This is secondary trauma happening right here every single time. I feel bad that I am telling you something that I don't think you want to know or that you need to know to help me. When in actuality, what they're going on and on and on about is so valuable, at least to this group, right? We can appreciate that it has tremendous value to us. Empathy. I want to say something about empathy. I'm going to assume every individual in this room at some point or another made the decision, the conscious decision, that they want to help your community, the individuals around you, help society, help heal individuals, research on how to make this world a better place, research how to increase the outcomes of healthcare, right? Made the decisions to be the most humane possible things. You made a lifelong decision to choose the profession that you are currently engaged in. And some point along the way, you lost the natural capacity to be empathetic to another human. That's a fascinating phenomenon to happen. We were watching Sarah's child the other day, playing around, just loving on people, just enjoying life. Children have empathy. If you ever are out at a playground, I'm actually a pediatric therapist by training. If you're ever out at a playground, especially with 5-year-olds, I love 5-year-olds, it's hilarious. A child falls, immediately there's a group of children surrounding that child, checking on them. There's so many, what do they call, mother hens around the playground. They're checking to see what, right? Showing empathy immediately. It's natural, it's inherent. We see it in nature. We see animals do it all the time in their own ways. Some of them are a little interesting, but it's there. We were all born with it. And here we are, the most qualified individuals that the globe has to offer. And we're talking about how do you be empathetic to another human? I would go beyond empathy. What the hell is preventing you from loving the individual across from you? When in the world's history did it become bad for a human to love and appreciate and be empathetic to another human that is suffering? The cultural impact that is there, that is influencing those things, stripped us somewhere along the lines, have no idea where, stripped us along the lines of some of these things that make us human. That's a tough pill to swallow. Our experiences of health and well-being are fundamentally influenced by the cultural context from which we make meaning. These frameworks inform the beliefs and actions of policymakers and healthcare practitioners as much as the people they serve. For this reason, policymakers must seek not only to understand the values they attribute to others, but also to critically examine their own cultures, their perceptions, daily practices, and processes of decision-making, and their effects on people who may or may not share the same values and priorities. Yet again, this is a document published by the World Health Organization by individuals that are much smarter than me. Mahalo. I think you're on break.
All right, everyone. So we're going to have a little dance session, a little movement break. Is that still going to be at 2:45? Yeah. So you have about a half an hour. Come on back if you're interested. Otherwise, the final speakers today will start at 4 p.m.